My name is Fyodor Panov. I'm one of the neurosurgeons at Mount Sinai West, and my specialty includes neuromodulation and minimally invasive epilepsy surgery, and I am the director of adult epilepsy surgery here. So seizures are incredibly variable. Seizures can be anything from a person just staring off to the side for a moment and not paying attention, to having what is more commonly perceived as a seizure, and that would be generalized tonic-clonic, where there's whole body shaking and loss of consciousness. I think the main thing to understand is anytime you're suspicious of having a seizure or a family member who had a seizure, it's important to see a physician to figure out what's going on. The main difference between seizures and epilepsy is you can have seizures and not have the diagnosis of epilepsy. You may just have one seizure your entire life. Let's say you were really stressed, drinking a lot of caffeine, or had head trauma. Those seizures are unlikely to ever happen again. Whenever you get the label and the diagnosis of epilepsy, that means that you will have seizures, and those will need to be monitored and controlled, and that requires an epilepsy team, epileptologist, potentially a neurosurgeon to be able to help. So initially, if you're seeing someone have a seizure, or if someone in your family is in trouble and calls you about having had a seizure, it's important to make sure the person is safe at that moment. If you see anybody who's seizing actively, please call 911. That's the most important way to approach it initially. Try to protect their airway and put them in a recovery position, which is off to the side, to make sure that they do not choke. The person to see initially after a seizure is either an emergency room physician or a family physician, but fairly rapidly after that, you should see somebody who specializes in epilepsy. And for us, that is a neurologist who specifically is called an epileptologist. Those are the best doctors to be able to see, who will be able to help you go from just knowing that you had one seizure to a potential workup and decide whether you have the diagnosis of epilepsy. It's a very common question. In approximately 2/3 of the patients that we see, medications work, and they work really well. The question then becomes, do you want to stay on these medications throughout the rest of your life, or should those medications be tapered down? And that is a conversation you should most certainly have with your epileptologist. If the medications are not working, and we know that that is about 1/3 of the patients, it is imperative that you come to a comprehensive epilepsy center. And there are a few of them around the country, and those are the areas in the hospitals that specialize on patients who have seizures that will not be helped by medication. We call that drug-resistant epilepsy. And this is a very important point to make. Even if you have one breakthrough seizure a year on medication, that still means that you have a very dangerous condition and you need to come to a comprehensive epilepsy center. The chances of the next medication helping, if 2 medications have been tried, are under 5%, unfortunately. We get this question a lot, and patients say, well, listen, this is under control, things are okay, I just have a seizure every once in a while. And I cannot overstate this. You have to come see an epileptologist and see what else can be done to control your seizures. So historically, the main surgery for epilepsy has been a resective surgery, and that goes back almost 100 years. But thankfully, over the last 20 years or so, we have made significant progress, and the types of surgeries that are available to help, both diagnostic, to help us figure out where seizures are coming from, and therapeutic, to help actually stop the seizures, have increased widely. From the most minimally invasive surgery you can think of, which would be a 2-millimeter incision, to advance a tiny little laser probe to the area that is causing epilepsy and to ablate it under live MRI monitoring, to responsive neuromodulation, which would be an insertion of a pacemaker for the brain into the area around here, underneath the skin, that monitors your epilepsy and is able to short-circuit it from spreading and prevent bigger seizures from happening. Historically, epilepsy does get a bad rap about big openings, big incisions, big scars that are visible. We have worked very hard in our field to keep the incisions as minimal as we can. So as an example, for a diagnostic procedure like a stereo electroencephalography, each incision is made with a 15 blade, and it's only about 3 millimeters in length. It's closed by 1 stitch, and almost no hair has to be shaved for it. So if you are visiting us as a patient 2 weeks after the procedure, your hair would look exactly like it did before. The therapeutic procedures vary from, again, minimally invasive, where it's just a small 2 to 3 millimeter incision, to larger incisions, which are still mostly behind the hairline, which means that once your hair grows back, the scar is almost impossible to notice. The range of epilepsy treatments really expanded once we were able to get better imaging, neuroimaging. The ability for us to see the patient's brain with an MRI was revolutionary to this field, as were the advances in electric monitoring. EEG is the workhorse of what we do in epilepsy, and that allows us to diagnose in which area of the brain potentially the seizures start and how they spread. And that requires putting little stickers on the surface of your head and spending some time in the epilepsy monitoring unit. Another amazing technology would be the advancements in robotics, which now help us inside the operating room perform procedures like the diagnostic stereo electroencephalography efficaciously and keeping the surgical time down, which is key to decrease infection rates. So the technologies of robotics, as well as the electrical analysis of the signal, as well as better imaging, have really pushed this field forward. So seizure freedom is the goal of our center and all the other centers around the country and around the world that specialize in medically refractory epilepsy. Our goal is to get you there, and we work very hard to figure out what is the best way for you and your family to arrive at seizure freedom. Nonetheless, for some patients, seizure freedom will not be possible. And then our goal together with you is to mitigate the seizures, to make them less harmful to your life, to make them less frequent, to make them less of duration, and to make your post-ictal, meaning the recovery after the seizure period, much shorter. And again, if patients do not have complete seizure freedom, most likely they will be significantly better. If the seizures before caused them to completely pass out and potentially hurt themselves, now they are seizures that have them lose consciousness for a much shorter amount of time, and they're able to recover quicker. Or they keep consciousness and are aware of the seizure, and that seizure lasts seconds instead of minutes. So I think those are all really important goals to keep in mind, and that's a good conversation opener when you do come to a comprehensive epilepsy center. What is the worst thing about your seizures, and how can we get that better? And the majority of patients will say the worst thing is the unpredictable nature of the seizures, and everything that we do at our center will get you to at least the level of being able to control the seizures better. For the majority of patients who have a seizure, surgery will not be needed. For the unfortunate third of patients who do have drug-resistant epilepsy or medically refractory epilepsy, surgery is an option. It's a valid option, and especially now with the advances in the surgical field, I want to make sure we stress the fact that it is not a last option. A lot of patients will take a small, minimally invasive surgery with known but very low risks, overtaking 2 or 3 medications for the rest of their lives, having those medications cloud their judgments and their ability to perform in the workplace and in their social life, knowing that, again, even with those medications, they still will potentially have a breakthrough seizure. So I want to stress this again, surgery is not the last resort. And as we're improving with the safety and efficacy of these procedures, it's important for us to get that message out. So unfortunately, that is the heartbreaking, gut-wrenching result of seizures. Seizures make it impossible for you to control your own body. And unfortunately, not only can you as the patient die from a seizure, but you can hurt others. We have had cases where a patient is driving and their seizures are not under control. And most certainly when you have a seizure while driving, you can hurt other pedestrians, you can hurt other drivers. It is difficult to talk about. We quote the rate of potential death somewhere around 1% a year for patients who do have drug-resistant epilepsy. Now, of course, that depends specifically on the kind of seizures that you do have, but it is an important question to discuss with your epileptologist, and it is one of the significant impetus to get the workup completed and to figure out, is there anything else that we can do as a team to help you with the seizures? Yes, so there's plenty of people in the history of mankind who have had epilepsy, as well as some current people who are in the limelight and also have this disorder. Historically, if we go all the way back to the before current era, Alexander the Great probably would be one of the most famous people who have had epilepsy, to the point where Caesar actually most likely faked his own epilepsy to appear more like Alexander the Great. St. Paul also had epilepsy. He wrote a significant portion of the New Testament. It is also very prevalent in the artist community. Van Gogh had epilepsy. A few famous musicians, including Grieg and Tchaikovsky, had epilepsy. Some writers, including the Russian Fyodor Dostoevsky, had epilepsy. If you think of the people out there right now who have epilepsy, an actor, Hugo Weaving, had epilepsy. I can think of also the rapper Lil Wayne, who's also fairly forward about his epilepsy diagnosis and the treatment. A lot of patients, a lot of people have this disorder. And if there's any silver lining from that is most certainly come to us, come to a neurologist, come to an epileptologist. Do not live alone with this diagnosis. A lot of people have it. A lot of people are able to live a good life with it once it's controlled. And if medications are not enough to control it, then most certainly come to a comprehensive epilepsy center where other potential interventions will be there to help you and get you to seizure freedom.